very short clinical detail. It's a 35-year-old gentleman who's come with fever for 8 days, worsening breathlessness for 1 day, and he was in shock on inotropes, tachycardic, tachypneic, requiring oxygen 4 liters. He had multi-organ dysfunction, and on examination, I'll just play the video. This is what we found. Just the eye is what I would like to focus on. This is the first one, somewhat similar. The second video. It's probably not very clear in this one. I'll play the first one maybe once more. Just yeah. So if I had to describe the movement, it would be a very irregular, very rapid, chaotic, vertical and horizontal movement. And the typical description for this movement would be, would someone like to volunteer? Or? Yes, that's opsoclonus. And so looking at the setting, opsoclonus in the setting of an acute febrile illness with multi-organ dysfunction in our epidemiological setup, what possible diagnosis would be considered? Could someone volunteer if possible?
Yes. Acute febrile illness, this particular. Huh?
Yeah, so that scrub is what we thought of. And on examination, so after the opsoclonus was picked up, on a detailed examination, the eschar was found. No, when the patient came to the ward, immediately when the patient came to the ward. Yes. So it's scrub typhus related opsoclonus, and I just want to share what I learned from this case. So the first thing is it's a very close differentials would probably be acquired nystagmus, which is usually unidirectional and has a slow component. The other very similar looking movement would be ocular flutter, but that is usually confined to the horizontal plane as per literature, and its opsoclonus on the other hand is multi-directional. I would just like to talk about this study, which is actually the largest descriptive study that we have for scrub typhus associated opsoclonus, and it's from our institution. And this is between 2012 and 2017. They looked at 1,650 scrub patients, in which 18 of them had opsoclonus. Just a few points to note in the study is that it predominantly featured usually by day 7 of illness, well into the illness, so not in the acute part of it, but well towards the end of the illness. So that is when the opsoclonus had actually presented. Among the patients with opsoclonus, nearly half of them had myoclonus, which our patient did not have. And a few of them had cerebellar dysfunctions and extrapyramidal syndrome, meningitis or meningoencephalitis, none of which our patient had. And the other thing that I would like to note is that nearly all of the patients in this study that we have from our institution, by 12 weeks, it resolves. Almost all of them recover by 12 weeks. Generally, this opsoclonus myoclonus syndrome is usually very commonly seen in children. It's a paraneoplastic syndrome with neuroblastoma, but it has been described in other viruses, TB, salmonella. Some paraneoplastic tumors in adults can also have like ovarian breast or non-small cell lung carcinoma also have this syndrome. Just a brief thing, the clinical localization of this movement disorder is actually to the brainstem, to the PPRF and to the vestigial nucleus of the cerebellar vermis. So we have two types of neurons. One is the burst cells and the omnipause cells. So these two are very much needed they need to work in tandem to kind of initiate a saccade, which is a very smooth movement. And what happens, the mechanism that is hypothesized is that there is a dysregulation of this, and which is what results in this very chaotic moment that we see in. There's the other major thing that I took away, that I learned from this, is that the fact that this is actually occurring towards the end of the illness. So our patient, it happened by day 8 of illness, and in the study that we saw, most of them had it actually by day 10. So what that actually tells us is that the pathogenesis is actually not because of the direct rickettsial invasion. Rather, it's due to a immune mediated hypersensitivity reaction. So the features of scrub, like hepatitis, ARDS, meningitis, all of them are because the rickettsia directly invades the vascular endothelium and causes damage. But this is because of, or at least it's hypothesized to be due to a hypersensitivity because of the scrub antigen. And that's the other thing that I learned. So in conclusion, it's quite rare, occurs in the resolving phase. Hence, the immune-mediated mechanism is thought to be the cause, and most of them recover. Our patient unfortunately had multi-organ dysfunction. He was in shock. He had severe ARDS. He went to ICU, and he could not recover, unfortunately.
He died.
He died. I mean, there was non-escalation of care. He was taken home. He developed. So what had happened was, with severe ARDS, he developed HIE, and he ended up requiring de-escalation. I mean, he did not do well. He was shifted out.
Thank you, John Roy, for that presentation. So as you've said, so most of these neurological manifestations, including known as myoclonus and scrub cerebralitis, usually occurs later, after day 5 of the illness. Day 6, day 7 is when it occurs, and it's most often due to immune-mediated response. So was any steroids given for this patient?
He was given steroid as a part of the shock, as a stress. Yeah, as a.
Any other questions? Okay. Thank you all for coming for today's clinical meeting. The best presentation goes to Medicine 1, Dr. Akash, for Worm in the Apple. That's all for today's clinical meeting, and I hope the attendance will remain the same for the next 1 year. Thank you.